Check it out now, y'all.
NanoHub U, online instruction.
Hello and welcome to NanoHub U's Introduction to Bioelectricity. In this lecture, we will conclude week 2, our examination into the chemical basis of electrical signals, with our 5th lecture looking into neurotransmitters and the pathologies associated with them. In order to look at neurotransmitters, it's easiest if we break them down into categories first. And so we begin by looking at small molecule neurotransmitters. These are the most common sort of neurotransmitters. And if you recall from the last lecture, these are neurotransmitters which are synthesized either in the cell body or locally at the terminal of the axon. And certainly they can be reuptaken and repackaged locally, which allows for more frequent release than the alternative, which is large molecule neurotransmitters. We'll get to those in a minute. They come in a variety of different structures. They're categorized briefly into amino acids, biogenic amines, and then acetylcholine in its own category. And we'll talk about some of these in more detail, most of these in more detail in subsequent slides. But for now, these are the broad categories in which you can classify small molecule neurotransmitters, and we call them small molecule, as you can imagine, because the molecules themselves are physically small. Neurotransmitters can be further categorized according to their postsynaptic effect. So acetylcholine and glutamate are excitatory, as are the catecholamines, which we'll talk about individually, which include epinephrine, norepinephrine, and dopamine. But then GABA and glycine are inhibitory. Recall from back in week 1 where we talked about how some neurons are excitatory, some neurons are inhibitory. The nature of these neurotransmitters gives you an idea of whether the neuron that you're examining falls into one category or the other. And conversely, if you're thinking about motor neurons which are excitatory, they're going to have an excitatory neurotransmitter. In that case, it's going to be acetylcholine. Interneurons, which are inhibitory, typically are usually going to use either GABA or glycine to communicate with other neurons. Large molecule neurotransmitters are much more rare, and as you can imagine, they're larger. But these neuropeptide neurotransmitters are classified also as excitatory or inhibitory and include neurotransmitters like serotonin and histamine, which you've probably heard of, and then a few others, including endocannabinoids, which we'll touch on over the course of this lecture. So let's dive right in and talk about these neurotransmitters one by one individually. So dopamine is an excitatory neurotransmitter. It's actually fairly uncommon in the brain. Only about 400,000, 500,000 neurons use dopamine as the neurotransmitter, but those neurons have an outsized influence. They project through a number of areas in the brain, key areas of the brain, that have very clear and visible effects if that dopaminergic transmission is impaired in some way. It plays a role in the ventral tegmental area, the VTA. Remember we talked about in the first lecture the naming of structures according to their physical position. So ventral, meaning towards the front, tegmental area is a nucleus in the cerebrum, and it's implicated in motivation, reinforcement, and reward. So the absence or presence or excess of dopamine will affect reinforcement reward pathways, which, as you can imagine, would lead to addictive effects. We'll talk about addiction more in just a second. Before, I want to mention something about the substantia nigra. We also talked when we were doing slices in the very first lecture of the brain. We were doing coronal slices, and we were looking at the caudate and the putamen and the globus pallidus, and I talked about how those nuclei are involved in the basal ganglia, which are in turn involved in locomotion. There's another nucleus called the substantia nigra, which is also a part of the basal ganglia or innervates the basal ganglia. And that nucleus can be divided into two parts, with the pars compacta, one of those two parts, projecting dopaminergic neurons to the caudate and putamen. When those neurons die, as happens in Parkinson's disease, you have a deficit of dopamine being released into the substantia nigra, or into the basal ganglia. And because dopamine is excitatory, you have a lack of excitation in the basal ganglia, which after several excitatory and inhibitory relays leads to an eventual lack of excitation from the from the VAVL nucleus of the thalamus up to the cortex and the primary motor cortex. And the end result is that you have an inability or a difficulty in initiating movements and in smooth movement motor control. And those are characteristic symptoms of Parkinson's disease. One approach to counteract this is to increase the levels of dopamine in the brain. And so you have drugs like L-Dopa, for example, which is a precursor of dopamine. And L-Dopa flows through the blood-brain barrier, so you can ingest it, and it'll go through the blood-brain barrier. Well, it will then be processed into dopamine, which will increase the average dopamine levels in the brain and counteract some of the effects of Parkinson's, at least in the short term. On the other side of things, you have the side effects of an excess amount of dopamine. And those are most easily visible in cocaine addicts. So what cocaine is, remember in the last class, we talked about how neurotransmitters are released into the synaptic cleft, and then small molecule neurotransmitters are reuptaken through specific ion channels that reabsorb them into the terminal, where they can be repackaged in vesicles and then re-released at the next action potential. Well, if you block those reuptake channels, then you have what's called a reuptake inhibitor. And dopamine reuptake inhibitors, like cocaine, lead to the effect that when an action potential arrives at the terminal and opens the voltage-gated calcium channels, the calcium flows in. That calcium leads to the vesicles bonding with the membrane. Those vesicles bond with the membrane, they open up, they release the neurotransmitter. You have that neurotransmitter, when it's not reuptaken, you have that density, that concentration of neurotransmitter for a longer period of time, which means that the effect of that neurotransmitter is increased, it's exaggerated. And so you have an average result of excess dopamine. And in cocaine, what you see is increased consciousness, increased awareness, increased energy, basically the opposite of the effects that you would see in a Parkinsonian patient. So it would work as a treatment, but it also, because it's implicated in the reinforcement reward areas, is extremely addictive. And as a side effect of it, you can have psychotic behaviors in the patient that takes an excess of cocaine, or in fact in patients that take L-Dopa. So a patient who was prone to psychosis and was also Parkinsonian would have a dilemma, because on the one hand they want to increase the dopamine level to counteract the effect of the neurons, the dopaminergic neurons of the substantia nigra dying, but on the other hand an increase in dopamine would worsen their psychopathy. So it's very interesting the way that these neurotransmitters work in the brain, and the way that you have trade-offs between having an excess in one area and a lack in another, and trying to take medications which treat neurotransmitter concentrations globally. And this is a theme that'll come back again when we get to week 5 and we begin talking about specific clinical applications, not the least of which will be Parkinson's in more detail. And that is that you have in standard medical treatment, when you need more of a particular chemical, you ingest it orally, and that increases the amount of that chemical throughout the body. So you have a global increase in the amount of that chemical. But in fact, what you want is only a local increase. We don't want an increase of dopamine everywhere in a Parkinson patient. We only want an increase in dopamine specifically in the substantia nigra. We don't want it in the ventral tegmental area, for example. And yet when you take a pill, you get it everywhere. And so a better way of delivering clinical therapy would be to deliver focalized drug or focalized electrical therapies. And again, we'll get back to that in week 5. But keep that in your minds for now as we go through the rest of these neurotransmitters. Norepinephrine is another catecholamine, another excitatory small molecule neurotransmitter, and it plays a role in several areas, but 2 that I'll call out today within the central nervous system. One is the locus coeruleus, where it affects attention. So an increase in norepinephrine increases your attention, your ability to focus on something. And also in the sympathetic nervous system, which is part of the autonomous nervous system. So we talked about the central nervous system in week 1 in the first lecture, we didn't really talk about the autonomous nervous system. So let me say something about that. Now, the autonomous nervous system is distinct from, or the autonomic nervous system is distinct from the somatic nervous system in that it controls those muscles that are involuntary. So, for example, your heart and your resting heart rate, your lungs and your breathing, which can be both voluntary and involuntary, but typically you're not thinking about breathing and it happens involuntarily, and a range of other muscle systems in the body, everything from the enteric nervous system controlling your digestion and your inner organs to the autonomic nervous system controlling vasodilation and vasoconstriction, so the opening and closing of your blood vessels. Norepinephrine is implicated in the sympathetic nervous system, which is part of the excitatory portion of the autonomic nervous system. So you can break the autonomic nervous system into sympathetic and parasympathetic portions. The sympathetic leads to a fight response and the parasympathetic to a flight response. So the fight response is increased awareness, increased focus, increased heart rate and breathing and muscle tone, and it prepares the body to fight. The flight response is the same and leads to a different reaction, which is to run away from an element. So in either way, you encounter a life-threatening situation and your body is pre-programmed to prime you to increase your concentration, your awareness, to do one of these two things. The alternative of fight or flight is what the parasympathetic system does, which is to relax you, to calm you, to lower your heart rate, to relax your concentration, to lower your muscle tone, and lower your breathing. Norepinephrine is involved with the first of those two, with the fight or flight response. Clinically, there's been a huge increase in the number of children being diagnosed with attention deficit hyperactivity disorder, ADHD. And there's a lot of debate about whether that is because there's an increase in ADHD, or whether there's an increase in the diagnosis, or to what extent there is an overdiagnosis, or in many cases to the fact that, for example, school curriculums that used to offer many separate recess intervals of greater length have been cutting out those recess intervals almost entirely, and so young boys particularly, young boys who don't have a physical outlet for their energy anymore are now internalizing that bottled up physical energy, and that leads to their inability to focus for extended periods of time. But regardless of what it is, there is definitely a correlation between attention deficit, and concentrations of norepinephrine. So there are drugs that are developed to increase the concentration of norepinephrine at the synapse, and amphetamines are the most well-known and most common of those drugs. Depression is also associated with reduced levels of norepinephrine, and you hear often about serotonin reuptake inhibitors, and we'll talk about those in a minute. There are also norepinephrine reuptake inhibitors, so selective norepinephrine reuptake inhibitors, SNRIs, which are prescribed for depression in many cases. Schizophrenia is a side effect of inappropriate balance of the norepinephrine levels in the central nervous system. And methamphetamines, which act like amphetamines, are one of the most common recreational drugs taken to alter the level of norepinephrine in the body. And they're one of the most devastating, if not the most devastating, of all drugs. Epinephrine is another small molecule neurotransmitter. It's also excitatory. It's the third of the catecholamines. So we talked about dopamine, norepinephrine. Epinephrine is the third. Epinephrine acts like norepinephrine, in some cases a neurotransmitter where it's released from one neuron to elicit a postsynaptic potential in the postsynaptic neuron. It also acts as a hormone, where it's more commonly known as adrenaline. And so it plays a role as a neurotransmitter and hormone. It also plays a role in the fight or flight response, where the adrenaline raises your heart rate, increases your muscle tone, increases your respiratory rate, leads to vasoconstriction, so a constriction of the blood vessels, which keeps more of the blood in the middle of your body and in the brain, and less of it in your extremities, and it leads to a muscle contraction, so increased muscle tone, enabling that fight or flight response. Clinically, it's used as a hormone to stop cardiac arrest. So it's injected directly into the chest cavity or into the bloodstream to stop a patient in the middle of cardiac arrest. So it'll reset the heart. It'll get the heart to start beating again. The next small molecule neurotransmitter I want to talk about is not a catecholamine. It's histamine. Histamine is also excitatory. Most of the ones I'm talking about are excitatory. It acts in the hypothalamus. It works exclusively through metabotropic receptors. So recall in the last lecture, we talked about the difference between ionotropic receptors, both of which are ligand-gated, but ionotropic receptors are receptors in which the neurotransmitter opens the ion channel, allowing the flow of sodium into the cell. Metabotropic receptors are receptors in which the neurotransmitter binds, and then the inside of the receptor, on the inside of the membrane, releases G proteins, which then travel to effector proteins, which then release secondary messengers, which can open a large number of neurotransmitter channels, of ion channels. So it is a slower process, but it has gain built into it. So a small initial release can lead to a large and a long-term, a long-lasting response. It plays a role in the immune response, and it does this by modulating the permeability of capillary blood vessels. So in the case of the immune response, it increases the permeability to white blood cells, allowing white blood cells to leak out of the capillaries and into the affected tissue and fight the infection that's present locally. It's also associated with the inflammatory response, where by increasing the capillary permeability, it allows fluid to leak out from the bloodstream and to inflame the local area to protect it mechanically from injury. It is implicated with the allergic reactions, in which one of the side effects that we're all familiar with, those of us who have allergies, is that it increases the permeability of the capillaries in the mucous membranes, increasing the amount of liquid flow into the nasal passages and leading to having a runny nose or runny eyes. So immune response, inflammatory response, and allergic reactions, clinically, it's also associated with a regulation of sleep. So an excess of histamine makes it more difficult for patients to fall asleep. It also regulates stomach acid. More histamine leads to more stomach acid, and a particular kind of over-the-counter medications for folks with heartburn are histamine inhibitors. And folks who've had antihistamines also notice that oftentimes you take a Benadryl, you fall asleep. It makes you very, very tired. It's the same thing. It's because it reduces the amount of histamine in the system, which then leads to you misregulating your sleep and falling asleep. And they're also implicated in the addiction pathways, not just addiction to drugs that involve histamine, but addiction to other compounds through reward pathways. The next neurotransmitter I want to talk about is serotonin. Serotonin is excitatory. It's derived from tryptophan, just like what you have in your Thanksgiving turkey. Though, contrary to popular belief, it doesn't seem that turkey makes you tired, or the tryptophan is so small in concentration. What really makes you tired is the quantity of food that you're eating. But regardless, serotonin is derived from tryptophan. It acts in the pons and the upper brainstem, in this area of the central nervous system. It also uses mostly, but not exclusively, metabotropic receptors. It plays a role in sleep, wakefulness, mood, and appetite, but what we know it best for is its role in depression and selective serotonin reuptake inhibitors, SSRIs. That's how drugs like Prozac work. It's also associated excess levels of serotonin with drugs like ecstasy, amphetamines, and cocaine as well. But getting back to the depression, one interesting thing is that Prozac, which acts as a serotonin reuptake inhibitor, is commonly prescribed for depression. And yet, countless clinical trials that have looked at the long-term efficacy of serotonin reuptake inhibitors for curing depression in mild to moderate forms of that disease have found absolutely no efficacy for Prozac in making patients better. But it is addictive. So interestingly, you have a prescription medication that is addictive and that creates a dependency amongst the patients, but doesn't make them better. Not at least in any double-blind scientific trial. Another neurotransmitter is acetylcholine. It's excitatory. It's broken down by acetylcholine esterase, and that'll become important in a minute. Acetylcholine or acetylcholine, depending on how you pronounce it, is best known for its role in the neuromuscular junction. It is the neurotransmitter that is used by neurons and released on muscle tissue to get muscles to contract. It's part of both somatic and autonomic neuromuscular junctions. It is the only neurotransmitter in the somatic neuromuscular junction, the voluntary muscles, and it is the primary but not the only neurotransmitter in the autonomic neuromuscular junction. Clinically, it often works on what are known as nicotinic receptors. So tobacco leads to an excitation of acetylcholine receptors or junctions and a sense of euphoria and relaxation. Myasthenia gravis is a disease that targets acetylcholine receptors specifically, and so drugs that act as inhibitors of acetylcholine esterase, which breaks down the neurotransmitter, serve indirectly as a sort of reuptake inhibitor. They're not really inhibiting the reuptake, but they're maintaining the concentration for a longer period of time at the juncture because there isn't the acetylcholine esterase to break it down. And so those drugs counteract things like myasthenia gravis. Taken a little too far, though, sarin gas works as an acetylcholine esterase inhibitor, and that's what sarin gas does. It basically paralyzes your neuromuscular junction by forcing the action potential to last for a very, very long period of time, overstimulating the postsynaptic cell, typically a muscle cell. Other small molecule neurotransmitters include glutamate and GABA. And I mention these last not because they're the least important. In fact, it's the opposite. Glutamate is the primary excitatory neurotransmitter in the brain and accounts for half of all synapses. And GABA is the primary inhibitory neurotransmitter in the brain, and it's involved in particular in epilepsy. And we'll talk about that in week 5. But epilepsy is commonly characterized as an excess of excitatory activity in the brain or a lack of inhibitory activity in the brain. And that lack of inhibition is tied to GABAergic neurons, neurons that release GABA being fewer in number and less active than they are in the healthy brain. And we'll come back to that in week 5. One interesting note is that GABA is actually an excitatory neurotransmitter in the developing brain. So it's an inhibitory neurotransmitter in your brain and mine. But when the two of us were embryos, it acted as an excitatory neurotransmitter promoting growth of neurons. So it changes its function over lifetime. And then there's a number of other drugs as well that affect neurotransmitters. These include opioids, like heroin and morphine and prescription medications, codeine and so on. They modulate pain and pleasure pathways, and they work on dopamine receptors and also opioid receptors, which are a peptide neurotransmitter receptor. There's cannabis or marijuana, which is particularly present in, it affects cannabinoid receptors. It's particularly present in the hypothalamus, where it regulates things like appetite. And it's primarily works through metabotropic receptors. It's most common with G protein receptors, like the ones I described earlier. And it has clinical uses for lowering nausea, vomiting in chemotherapy patients, for example, and reducing intraocular pressure in the short term in glaucoma patients, and a few other applications. So that's a brief overview of neurotransmitters. There's a lot more to be said about each of these neurotransmitters, and indeed, many folks spend their entire careers studying how a specific neurotransmitter or a specific ion channel works or how they work in tandem. But this will serve as our introduction with this course, and we will end week 5 on this note, or week 2 on this note. In week 3, starting in the next lecture, we'll begin to look at the models that we develop to describe electrical activity in these neurons and how they account for the various phenomena that we observe in the laboratory. I'll see you then.